Hello, my name is Rebecca McComb. This is a presentation on stroke care in the emergency department, specifically effective stroke care and TPA administration protocol in the emergency department. This is my PDSA project for Nursing 450, Nursing and Leadership. So how is a patient determined to be a candidate for TPA? First, a last known well time of less than 3 hours is needed to be determined in order to give TPA without consent. If the last known well time is determined to be less than 4.5 hours, then consent is required because there are higher risks involved in administering TPA between 3 hours and 4.5 hours. After 4.5 hours, TPA is contraindicated and no longer a viable option for the acute stroke patient. Other things that need to be determined are the severity of symptoms to determine if TPA is an appropriate treatment, and that is determined based on an NIH stroke scale. Also, assessment of inclusion and exclusion criteria. There's a long list of exclusion criteria that has to be evaluated for each individual patient. For example, if a patient has metastatic cancer, then that excludes them from TPA administration. If the patient has received TPA in the last 3 months or has had a hemorrhagic brain bleed in the last 3 months, that's also exclusion. If the INR is above 2.5, patient cannot receive TPA. So there's quite an extensive list that has to be, that you have to go over in order to determine if the patient is appropriate. The inclusion criteria is much smaller. Inclusion consists of the patient being diagnosed with an acute stroke, the patient being within the last known well time of less than 3 hours, no consent needed. If it's between 3 hours and 4.5 hours, then consent is necessary. And the neurology consult has to be done, and then, a physician is able to also determine if TPA is appropriate, but it's best to come from a neurology consult. So all of those things are determined if a patient is able to receive TPA or not. So what are the current standards and protocols in place in the emergency department for acute stroke patients? These protocols they come from Riverside University Health Systems protocols for the emergency department during code strokes. So when a patient comes in initially through the ambulance bay or through triage, they are assessed by an attending physician or a resident. They have to be assessed by the attending physician, but a resident is able to take over care, and that has to happen within 10 minutes of the patient's arrival. An NIH stroke scale is accurately complete by either the primary RN or the code nurse, and that should be done within 15 minutes of patient arrival. CT is to be complete within 20 minutes of patient arrival. The CT is to be read by the radiologist within 25 minutes of the scan. Labs are to be resulted within 45 minutes of patient arrival. And TPA, the ultimate goal is for TPA to be administered within 1 hour of patient arrival. So who are the stakeholders involved in the care of an acute stroke patient? Number one is the patient. They're the most important stakeholder because it's their life, their quality of life, and their outcomes that mean the most for that patient. The family of the patient being evaluated is another stakeholder. The institution, to ensure stroke certification is maintained, there are high financial stakes involved in stroke care. Liability. The healthcare team is held responsible for correct and fast assessment and treatment of acute stroke patients. So they are also considered stakeholders in this process. So quality variance. The issues that I identified that are in need of improvement in order to accomplish the goal of administering TPA within 1 hour of patient arrival, I've identified 3. The most important: ensuring the accurate NIH stroke scale is complete and documented within 15 minutes of patient arrival, lab turnaround within 45 minutes of patient arrival, and that IV TPA mixed and received from pharmacy has been shown to be to delay the administration of TPA. So all three of these need intervention in order to improve the door to needle time of TPA. Root cause analysis for the NIH stroke scale to be completed within 15 minutes. So NIH is the foundation of determining if a patient is having an acute stroke once the last known dwell time is determined to be within 4.5 hours. NIH stroke scale assessment is able to be accurately determined within 10 minutes of patient contact and must be determined before moving forward. We're unable to say if this patient is having a stroke or not if the NIH stroke scale is not completed and done accurately. A lot of education is involved in that. It's shown through quality reporting that the NIH stroke scale was taking up to 30 minutes, which is half of the allotted time. So interventions needed to be in place in order to speed up that process. And we'll talk about those right now. So interventions for improvement. All emergency department staff, and this has always been in place, but I just wanted to note that everyone who works in the ER is required to have NIH stroke scale certification in order to work in the department. Staff is provided resources such as laminated NIH stroke scale tools for use and reuse. Provide a complete NIH stroke scale tool, including large pictures in both English and Spanish on every adult crash cart in the department. So we have a high population of Spanish-speaking patients, and having them both in English and Spanish is really important in order to speed up the process. Provide an ongoing support to those that utilize the assessment tool infrequently. 24-hour RN code team and stroke program coordinator to assist and guide. So the code team comes down and acts as a very important resource at the bedside to speed things up and to have things done correctly and accurately. They're a wonderful resource. Identify and utilize designated unit stroke champions as resources. Now, the reason this is being implemented is because if there's experts on the floor, you're able to draw from them and ask them questions, and they're supposed to know the protocols and procedures, everything that's required to a very specific level, and they're always on the floor all throughout the hospital, but in the emergency department, it's very important as well. Stroke Cardex is a tool that outlines everything that's required to be done in order to administer TPA, as well as follow through with, it follows the patient up to the floor, and protocol is continued through their care on the inpatient side. But the Stroke Cardex tells you what the NIH stroke scale was, and if aspirin was administered, and it just goes through all the different things that are required for the stroke patient, and that's an important tool to use. NIH stroke scale assessment is highlighted in the department as an independent function that does not require any kind of physician order. It's an assessment, and it should be done immediately upon patient arrival. It should be done as the patient is in progress to CT and in progress back to the bedside in order to be completed within that 15-minute time frame. All materials printed and laminated and placed throughout the unit, and there's also a stroke resource box available to all RNs in the radio room of the emergency department, and that was implemented through this project. Many of these were actually. How will we know that our interventions are working? Compliance of the NIH stroke scale entered in the EMR and documented within 15 minutes of patient arrival. To be placed in the EMR after patient activities are complete, patient care and tasks should never be delayed in order to chart in the EMR. Patient care comes first. Neurology consult should be underway within 45 minutes of patient arrival. An accurate NIH stroke scale is necessary in order to give the neurologist the most information, and the NIH stroke scale is repeated during the neurology consult while the neurologist is watching, either through the telehealth or if the neurologist is at the bedside. NH stroke scale within 15 minutes will translate to improved door to needle time to at least 75% of all patients who receive IV-TPA treatment as specified by the Joint Commission, and this is tracked through quality reporting that is completed throughout the year. So the next thing that we're going to talk about is the lab turnaround time of less than 45 minutes. So some of the problems that have been determined through quality reporting of last year, it was determined that the lab turnaround time was taking 66 minutes, and the standard is less than 45. So already we weren't meeting on average the goal of door to needle time within 1 hour. So platelet and PTT-INR values are required to analyze if the patient's inclusion and exclusion criteria. If the platelets are too low, the patient can't receive TPA. If the INR is too high, patient cannot receive TPA. And that's part of the exclusion-inclusion criteria that are used as a resource in the stroke box. TPA can't be administered without knowing those results. So interventions to improve lab turnaround time, we've implemented a lavender lab slip instead of the current yellow lab slip. So lavender indicates to the lab technician that this is an acute stroke, that everything else should be put down, and that the stroke labs are taking precedence because, again, time is brain. There's a dedicated certified nursing assistant that has been implemented to run the lab specimen down directly to the lab technician, bypassing the normal intake process. Encouraging staff to obtain blood products prior to CT whenever indicated, as long as the lab results will not delay CT, getting the CT, because that shouldn't happen. We need to know if the patient's having a bleed or not. Implementation of the laboratory technician to call the ordering department to speak directly to the charge RN to verbally give the results of the platelet. So it was found that the lab wasn't reporting the platelet value until the entire CBC had been resulted, and then they would upload and give the whole CBC result when all was necessary to determine TPA administration was the platelet result. So it was found that within 8 minutes, the platelet result was ready, and the other labs were taking longer. And so we've implemented that the person running the lab will call the charge nurse in the emergency department, give it as a critical value, and then that's logged into the critical value log as documentation and to match up times so that that can be tracked. Implementation of a point of care PT-INR to obtain coagulation studies within 30 seconds of specimen obtainment has deleted, or it has ended the problem of waiting for the INR result, which was really lagging down. We found this the lab resulting time. So all of those have been implemented in order to decrease the lab turnaround time. How will we know that our interventions have worked? Results will continue to be tracked through quality data reporting throughout the year. Feedback from the code team is very important. Again, neurology consult will be underway within 45 minutes of patient arrival. Successful lab turnaround time will result in improved door to needle time, and that's how we'll know that our interventions are successful. Last intervention that I evaluated is IV-TPA being received from pharmacy. Now, this was proving to be quite a problem, that it was determined that there are delays in patient care related to IV-TPA being mixed and sent from the pharmacy. Waiting for TPA to be received from pharmacy can't be a factor in administering TPA. There shouldn't be delays because we don't have the medication. So it was determined that TPA should be available in the Pyxis and reconstituted by 2 RNs at the bedside. So we'll talk about the implementation of those interventions. So again, it was made available in the Pyxis of the emergency department. Resources are available to detail the amount of drug to be wasted and administered based on the patient's weight that's obtained from a weighted gurney. There's a chart that 2 RNs are to refer to that, based on the patient's weight, tells the nurses how much is supposed to be wasted from the reconstituted TPA, how much should be bolused within that first minute, and then the remaining of how much should be given within 1 hour. And that's determined by 2 nurses at the bedside who do it together. They discard together, they program the pump together, and they start it together. And then that's all documented in the EMR. And then the code nurse is available as a resource during all code strokes to help with reconstitution, as well as the pharmacist being on standby in case there are any questions or concerns regarding the TPA reconstitution. How will we know that our interventions have worked? So IV TPA will be available and ready to infuse within the 1 hour time frame. Delays related to availability of TPA will be documented and tracked through quality data reporting. Feedback from the code team, as well as IV TPA will be hanging and ready to administer during neurology consult in case TPA is indicated for neurology approval. These are the references that I used to help develop my interventions and determine what was most appropriate during code stroke. I had extensive help from Deb Brim, who is the stroke coordinator, and we went through and created this project together, and a lot of time and effort went into this, and I just want to thank her for everything that she did for me, and thank you very much for listening.